Good evening, Kenya, and welcome to this presidential town hall conversation on health. My name is Dr. Mercy Korir. Our constitution makes a solemn promise that every Kenyan has the right to the highest attainable standard of health, and that no person should be denied emergency medical treatment. For far too long, the experience of many families tell or fall short of that promise. In 2022, President William Ruto promised to change that reality, to build a health system in which care is a right for every Kenyan, not a privilege for those who can afford it. 4 years later, the question before us is simple. Are Kenyans better off today than they were then? The answer must be found in the lives of real people. The mother who delivered safely without facing a crippling bill. The cancer patient receiving specialized treatment closer to their home. That grandfather whose dialysis is now covered. And the family visited by a community health promoter before a manageable condition became a medical emergency. That is why we are here this evening. Not merely to recite or enumerate what has been done, but to examine what has changed, not only to celebrate progress, but to confront the gaps that remain, and not simply to speak about citizens, but to hear directly from them, from you who is in this room tonight. Tonight, patients, families, community health promoters, doctors, nurses, hospital administrators, and public health officials and other public officials will help us test the reform against lived experience. Because the true measure of health reform is not the institution created. It's not the money allocated or the policy announced. It is that patient who has been treated, the life saved, the cost avoided, and the family that has been protected. Ladies and gentlemen, welcome to an open conversation about the progress Kenya has made, the work that remains, and what it will take to make quality healthcare reliable and accessible for every Kenyan. Let's begin.
Do hereby commit to establish the Hustler Health Care Program. By December 2022, every Kenyan, including every Kenyan woman, shall be insured or shall have health insurance at affordable premiums, and where they cannot afford, the government of Kenya will pay for the women who cannot pay. Secondly, I commit to ensure that adequate numbers of community health volunteers and establish a cost-sharing framework between national and county governments in the payment of their stipends. I commit to provide mothers of newborn babies with diapers for their children for a minimum of 3 months paid for by the government of Kenya. We are not having a conversation about politics. We are having a conversation about life. We are having a conversation about our loved ones, people we cherish and people we love.
36% of Kenyan households, 1 out of 3 households, is at the risk of being impoverished by a catastrophic illness costs. 1 out of 3 Kenyans.
We must figure out how we are going to start at the bottom. How the health center, how the dispensary, how the community health worker
is going to be empowered sufficiently to be able to deal with the challenge right at the root.
A conversation
if
about
the dispensary
politics.
is working.
We're having a conversation about
If the will work.
I want to talk about, which I know you can make an immediate impact, is healthcare financing. I think we should have a mixed model of health financing. Let me explain a bit. In financing, again, support both public risk pooling and private risk pooling. And you've mentioned it many times. And if you can contribute to NHIF according to your salary scale, rather than just a fixed 1,700 shillings, and it is pegged on salary, we could be considering it as a levy.
When we had the issue of emergency response, and this is a challenge that has been going back and forth. You have got people who get accidents and they rush to health facilities. Who is supposed to meet those bills? There was a proposal in 2017, and in fact it was legislated that there was an emergency response fund which was supposed to be set up. It has never been operationalized, and that needs to be done so that you can also encourage, for example, private health facilities are run by private investors. You cannot have them incurring huge costs which are never compensated consistently to be able to take care of, and that you know it's also against the law to be able to detain people for not paying bills. So there are a lot of facilities, especially those who are located along major highways, incur to be done so that you can enormous cost in terms of being able to provide healthcare services to citizens, and I think that's the role of the emergency response fund.
We want to see issues of healthcare workers improve in this country 100%. We want to see issues of HPTs and technologies, healthcare products and technologies improve. We want to see issues of digitization optimal. We want to go to the optimal level, and health financing at the same time. Yes, we have moved leaps, but we want to go even further.
Kuna uchache wa CHPs. Mali kuna uchache, atuongeze tuko wengi.
We could make use of the community health providers to go down to the ground, to the mwananchi, to the mama mboga, to the boda rider, and just tell them whatever is available in the facilities, in terms of equipment and in terms of service provision.
I look forward to the President continuing providing that leadership that is required in ensuring universal health care is taken. And it's not just about the President, it's more important even we as citizens. If everyone takes their responsibility seriously, then nothing can stop us from achieving what we need to achieve.
About rubber meeting the road, that Wanjiku can access the care they need. Let me not even say care, the help they require. Help comes from both preventive, going to promotive, to now curative, as we're in curative.
Expectations for the improvement of services as we reach out to our households. We expect to be equipped with better kits and new kits, and the refills that are lacking.
We in the health sector have to up our game. One is to ensure that we achieve universal health care in our country. Two, that we provide impeccable and similar services to our Kenyan people. Three, that our Kenyan people access all these services, cheaply or in an affordable manner. That will make Kenyans healthy. Similarly, we also want to see how best we can actually create more efficiencies by automation, digitization, and embracing technology in healthcare space, because that's where the world is going.
We have called Kenyans here because health is a collective responsibility. It is not a one-man show.
Those were some of the expectations from allow us to welcome His Excellency the President to come and join us. When he's almost here, I'll just let you know so that we are able to welcome him. But as we wait for him to come, the reforms that this administration did were 4 major reforms. The first one was on the public health care. where we've seen community health promoters, and some of them are in this room. They'll be able to speak about their experiences and some of the people who have benefited from having community health promoters at their doorsteps. The one that all of us have been talking about the most is the Social Health Insurance Act that birthed SHA, the Social Health Authority, and marked the end of NHIF, the National Health Insurance Fund. The third one was on digitization, the Digital Health Act, which you should be able to unpack. And most of us have read, seen, heard a lot of stories about DHA. We'll be able to unpack all of those questions during this town hall. Then the fourth one was on the Facilities Improvement Fund, about facilities getting their own funding, investing in their own facilities, having that autonomy to decide what to invest in as a healthcare facility. We'll be able to hear from governors about their experiences, about, implementing some of these acts, implementing some of these reforms. But most importantly, like I'd said, as I began this town hall, is that we want to hear from you, the citizen. These reforms are about our healthcare, about your healthcare. It's about that mother who's in a village. It's about that man who's seeing us and that woman who's seeing this town hall. And they have very many questions that they've been wanting to ask or they've been seeking answers. So the people who are here in make it to this town hall, you will have an opportunity to ask any questions on their behalf. You'll be able to get clarity on some of the issues that we think need to be addressed in the healthcare in Kenya. So, ladies and gentlemen, President of the Republic of Kenya, let's be upstanding and we welcome the President. Let's appreciate the President as he walks in. Let's give him a warm, hearty round of applause as he comes into the room for this inaugural presidential town hall on health. Let's be upstanding as we welcome His Excellency President William Ruto, who will be able to take us through this town hall. Karibu sana, Your Excellency. Karibu sana, Your Excellency. Ladies and gentlemen, you can take your seats. Your Excellency, as we plan to start this discussion, I'm a media practitioner as much as I'm a medical doctor. I want us to see and address a certain elephant in the room.
Millions of Kenyans. How much?
These are some of the headlines.
And whether you even receive healthcare has been decided by an opaque artificial intelligence system. You don't get to see it. You don't get to question it. You just get a number. But for many on the ground, an entirely different reality is unfolding.
In the community, perspective and expectations. Walidhani ni kitu itawasaidia kulingana na venye ilitangazwa na serikali. It is so tricky. Unapata mtu aweza afford a meal a day. Unapata anaambiwa he or she is supposed to pay 650 and above. Pesa hata yeye aweza afford. Kwa hivyo tangu SHA ikuje kumekuwa na crisis.
Our audit found that it overcharges the poorest Kenyans while undercharging the wealthiest. We also obtained a document showing that the government knew of these risks but launched the system regardless. Knew of these risks but launched the system regardless.
Mr. President, those are some of the things the media has covered. But I want to take you back to 2022, where you made certain promises. One of them was that any mother that delivers will get free diapers. I thought in 2023 I'll be one of the first beneficiaries. I didn't get diapers. What happened?
Thank you very much, Mercy. And good evening, everybody. Welcome. This is a very good event, and thank you very much, Mercy, for asking me that very important and pointed question. But let me put this in context. There are many people who say I was elected in 2022 merely because I said hustler and bottom up. Today, I think you have seen that I made commitments. I had a plan. And I made commitments to the people of Kenya. And it is on that basis that the people of Kenya gave me a mandate. And it is what is expected of every leader, that if you want the mandate to lead a country, you must give the people your plan, your vision, your commitment on what you're going to do. And this evening, I am going to answer, and I'm very happy I saw the commitments I made before the election in 2022. Number one, I think I made like 7 or 8 commitments on matters health alone. 7 or 8 commitments. Commitment number 1, I said that we are going to have a health system that is going to make sure that every citizen can have access to health care. I called it that time hustler. But we came and said it should be called Social Health Authority. Today, my commitment on making sure that we have a system that works, a system where Kenyans can access health in a predictable manner, today is a reality, and 32.3 million Kenyans are registered on that platform. Number 1. Number 2, I made a commitment that we are going to have community health promoters. I said then, in good numbers. I can now stand here before you and the people of Kenya that we have 107,800 community health promoters. Trained, properly, deployed, and their stipends paid. I committed then that I was going to work with counties to make sure that their stipend becomes a shared responsibility between the national government and the county governments. Today, half the stipend of community health promoters is paid for by the national government, half the stipend is paid for by county governments, and I want to thank the county governments for working with me on that platform. I did make a commitment that we are also going to make sure that those people who cannot afford to pay, you remember the commitment I said is that everybody is going to pay as per their ability. And those who cannot pay, will be paid for by government of Kenya. Today, each and every one of us is paying in accordance with their ability, a percentage of their income. And those who cannot afford to pay, the indigents, we are paying for 560,000 households, representing 2.2 million citizens who the government of Kenya is paying for. That goes to the bottom of what commitment I made, that those who cannot afford will be paid for by the government of Kenya. And secondly, we are also paying for all teenage mothers, because we understand that every teenage mother doesn't have the money, and there we have provided resources for the government of Kenya to pay. Number 4, in that clip, I made a commitment that we are going to work on this from the bottom. I said every health center, every dispensary, every level 4 hospital must work for level 5 and level 6 to work. What have we done? Today, every health center, every dispensary, and I am sure there are people in our midst here today who are managers of health centers, managers or heads of dispensaries, who are going to tell us the difference that has been made by the reforms that we have carried out to every facility at that level. Today, every health facility, every dispensary, number 1, has a management board. Number 2, every facility today, for every patient they see, at the end of the month, they are paid by SHA. Every facility, every dispensary. Because I made a commitment that we must make the dispensary work, we must make the health center work for facilities on the higher level, level 4, level 5, level 6 to work. Today, with confidence, the governors are here, the managers of those facilities, I'm sure they are represented here, they will tell us the difference we have made. Number 4, I made a commitment that we are going to make sure that every mother, the question Mercy has asked me, every mother who gives birth, when they leave hospital, we are going to make sure that they have diapers. Right? That is a commitment that I must fulfill. Because we have already set the mechanism in place. We have already changed the way our Linda Jamii program operates. You remember, the Linda Mama program operated differently from the Linda Jamii. The Linda Mama focused on the mother and on delivery. Today, the Linda Jamii program focuses on the mother, focuses on the child, and focuses on the household. The numbers have changed. Linda Mama was 2,500 paid or refunded for public facilities, 3,500 for private facilities, 6,500 for cesarean section, 10,000 for private hospitals. We have changed that metrics. Today, from 2,500, we now pay 10,000 for all facilities, irrespective of whether they are private, public, or faith-based, for normal delivery. We have increased 4 times what was being paid. Number 2, for cesarean section, which was 5,500 in public facilities, 10,000 in private facilities, we have raised that up to 30,000 for all facilities. So we have equalized all the facilities, because a mother giving birth in a private facility is as good as a mother giving birth in a public facility or a faith-based facility. We have equalized that whole space. And because we have built now the ecosystem, just 2 weeks ago, you remember the gentleman who asked there and said about emergency, and that he told me that time in 2022, I think it was June, he told me government must operationalize the emergency facility because too many people will lose their lives, because in an emergency, if you go to a hospital, the first thing a hospital will ask you, who is going to pay the bill? And in the process of asking all those questions and finding out who will pay the bill, we lose lives, we lose people. That is why we went to Parliament, we passed the law, we now have an emergency, chronic, and critical illness fund that now funds emergencies. And 2-3 weeks ago, we launched that facility, which comes complete with an ambulance facility paid for, emergency service for the first 24 hours paid for, and beneficiaries don't have to be members of any insurance facility, including SHA. You don't have to be a member of SHA. So long as you are in an emergency, the government of Kenya, as was requested, as I was told in 2022, and I committed to do it, today I have discharged that responsibility. 2 weeks ago, we launched the facility and we are moving. You remember, in that clip, I promised that we were going to have the health insurance by 2022 end. It wasn't possible until 2023 end. Why? Because of the process. We were taken to court, we were stopped here, we had to go back, we had to do this, but ultimately, we've kept that promise. We have now finished with the emergency. I can tell this auditorium that by the time I complete my term, my first term, I can tell you I will have discharged all the commitments I had made and made sure that every mother who walks out of hospital will walk out with the diapers once they give birth. Let me also say, another gentleman, and I wish he was in this room today, who told me that time that I was a candidate then, Mr. Deputy President, please find a mechanism where citizens can contribute, not a fixed number as we were doing, but a percentage of their income, a percentage of their salary. Today, in this auditorium, all of us know here that each one of us contributes 2.75% of their salary or income. The people who are paying the most at 5%, have come down to 2.75%. Those of us, like me, who was paying 0.01% of my salary, today I pay 2.75%. We have made contributions equal as a function of your income. That was what I was asked by that gentleman. That is what we have done. So, in short, on that list of the commitments that I made to the people of Kenya, I will be ready for the exam next year. I will be ready for the exam next year. And my target is to get 100%.
Okay, all right. Sorry for that. Thank you. Those are very good. But I want to take you to the headlines. One of the headlines was SHA ni Chief Nivilio na Mateso. And the other one, and I'm glad that some of the members of parliament are here, the MPs actually are saying SHA isn't working. But here you're telling us SHA is working. We have X number of Kenyans who have been registered. What do you have to say? And it's been...
Thank you very much, Mercy. That is great. That's another beautiful question. Because facts are very stubborn, you know. And reality is different from what gets said. One of the headlines tells us, for example, that there is a 104 billion shilling skunk on our digital health program. That we had signed a contract of 104 billion. I think this one here, the skunk, you know, of 104 UHC take upgrade. First, let me tell you that there is no 104 billion contract. First, what we have done is we have designed a digital system, and I want to say this with clarity. This whole ecosystem would not have been possible if we didn't have a digital system to make sure that everything, as I said earlier in the day, that every patient must be visible. Every treatment must be traceable. And every payment must be accountable. That is what the digital system enables us to do. And Akili, what did we do? We did not buy the system. Just the same way today we have MRI machines, we have CT scan machines, we have theater machines worth billions of shillings, but we haven't paid a single one of them. What we have done, what we have told manufacturers is they invest in the machines. They bring the machines, we pay for service. For every one service, we pay. It is their business to maintain, to make sure the machines are working. It is their business to make sure that the machines are operational. They service the machines, they provide the consumables. Ours is not to buy machines. Ours is to provide service for citizens who want treatment. It is the same thing we did. We asked companies to invest their money in a digital platform, a health digital platform. They invest the money, we pay for the service. And we went to Parliament. And we went to the Kenyan public. and we agreed on the rates. We said that for SHA and all the other facilities, we are not going to spend more than 5% of the resources we collect from the people of Kenya for management. And for your information, the management cost of 5% includes the payment for the digital platform that we are using. Do you understand what I'm saying? Let me repeat. Let me go back. The management cost under NHIF was 40% of the collections at one point. In 2022, it was 17% of collections went to management. Under SHA, we have brought down management cost from 17% in NHIF to 5% in SHA, number one. And the cost of technology that we are using is included inside the 5%. That is where we begin. And we have said, for facilities, and I saw one of the headlines there saying that there is a ghost company being paid 1.2 billion by hospitals. You know, for your information, hospitals do not pay any private entity. Hospitals pay DHA. And the cost is this, so this skunk thing is a fallacy. You know, ile mimi naita saa zingine ufala, ndio hiyo. Na hiyo 1.2 mnaona pale, there is a 1.2 billion sijui some farm. I can confirm to you that that is money paid to DHA. And the money paid to DHA is in law. Facilities pay 2%, but with a maximum of 5,000 shillings per claim. And it is in law. It is not something you go and negotiate in the bush. It is in law. And we have made sure, and I can answer any question from anybody on the amounts of money we are paying for technology, and every payment is underwritten by law in regulations to make sure that we protect public assets. Let me ask the good gentleman from DHA, Anthony, is right there. Anthony there is a professional. He's not a politician. And he is the CEO of DHA. Anthony, can you speak to this 100 and something billion contract?
Thank you, Your Excellency. It is not correct and not true that Social Health Authority has done any upgrade on any government has invested in 104 billion technology upgrade. Your Excellency, what we did is build a digital superhighway consumed of 43 systems, Your Excellency, to support universal health coverage. What are these systems, Your Excellency? The first is we realize our public hospitals, where many Kenyans go, do not have digital infrastructure to provide services online. Your Excellency, we brought to them 4 key things. Number one, Your Excellency, we gave them gadgets, which are tablets or computers, that the private sector has invested for a period of 10 years with all upgrade, all maintenance, and all support. What has that done to us? Today, Your Excellency, the public hospitals where many Kenyans used to go and get services, Your Excellency, used to receive only 35% of PHC under NHIF. As we speak today, 62% of that money is going where services are being provided. This is because we enhanced the digital infrastructure at the hospital level. We gave them, Your Excellency, software. This software has helped them with efficiency. This software, Your Excellency, helps them to track and be accountable for every patient, for every claim. During the days of NHIF, hospitals used to have files. They used to be approved in batches. They used to be transported, taken to county NHIF offices. They will still be transported, taken to the regional offices for approval. They will still be transported, taken to headquarters for approval. They used to be approved in batches. They used not to be checked. There was no accountability. As we see today, Your Excellency, every claim is tracked because we have enhanced that public sector, Your Excellency. The second area that we looked at the superhighway, Your Excellency, is many Kenyans used to go to hospitals. When they're in the hospitals, they will receive a service. But that service, how they have been written, how they have been identified, is different in the second hospital. That is why you couldn't work with your data. That is why you couldn't have data portability. We looked at 6 key systems in that area. One is the client registry. Every Kenyan today is identified uniquely using your ID and your fingers. It eliminated all the cards that we used to print. And that is the role of technology, is to bring efficiency, Your Excellency. The second part was on the facilities, Your Excellency. You remember there were facilities that were doing more surgeries than Kenyatta, Your Excellency. And they will use that because there was no digital system. They will use that to do claims. They will use that to frown public funds, Your Excellency. Today, we have a single point of truth for every facility to safeguard the safety of Kenyans. No facility can provide services in this ecosystem if you have not been licensed in that, to provide those services. No facility can provide services that has not been licensed, Your Excellency. That is what has eliminated what we used to have, like the hospital that is in Kino, Your Excellency. We looked at the health workers, Your Excellency. There used to be fake doctors that want to use the doctor's professional, Your Excellency, and cheat Kenyans. You will walk to hospital. You don't know, Your Excellency, whether this is a doctor in front of you, Your Excellency. We created a single point of truth where only licensed doctors, the specialties they have, Your Excellency, the systems only allow them to provide that service, Your Excellency. We look at other areas, Your Excellency. Many Kenyans used to walk. They carry books, Your Excellency. Those books used to be get lost, Your Excellency. We provided what is called a shared health record, Your Excellency, where today, if you download the Afya Yangu app, you will see all your claims, you will see all your prescriptions, you will see all your doctors, and you are able to see all your information within your phone. That eliminates all the paperwork that, Your Excellency, we used to have. That area, Your Excellency, is called Health Information Exchange. We are the second country in Africa to be and the 10th in the world, Your Excellency, to do that, Your Excellency. We look at the whole area of, Your Excellency, logistics. KEMSA digitization, Your Excellency. How do we ensure that the drugs that are provided are correct? How do we ensure the safety of the drugs of Kenyans? We track these drugs from the manufacturers to the time it is dispensed in the patient, Your Excellency, for the safety of the Kenyan people, and as well as to ensure that the drugs that are dispensed are only the authorized drugs. That system has 3 key ecosystems: a national logistic management system, a track and trace management system, as well as, Your Excellency, what is called order management. You saw today, Your Excellency, in some of our counties, the counties do not have to wait to see where are the trucks that are bringing our drugs. They don't have to wait, Your Excellency, to see which drugs I need to order. Before they will order a lot of drugs, Your Excellency, they will put them in store, but maybe their demand does not need them to do that, Your Excellency. Today with this ecosystem, we are not, the public hospitals as well as our ecosystem is not to provide that, Your Excellency. We looked at the areas of telemedicine. We don't have enough expertise. How do our doctors consult? How do they talk to one another? How do they support the patient to provide them the best services? And we brought in the telemedicine platform that are running in our ecosystem, Your Excellency, today. Your Excellency, we looked at the analytics. You saw today, Your Excellency, we are reading patterns. We are able to see patterns of hospitals that want to defraud our ecosystem, Your Excellency. And we're able to analyze them. Systems are for efficiency, Your Excellency, and that is what we have built. 43 systems, Your Excellency, that does not only support SHA, but more protect the Kenyan people from fake drugs, from fraud, and give them efficiencies, Your Excellency.
Can you tell us, Anthony, how much money have you paid to the service providers in the last 2 years under this program, especially for SHA, for example? How much money have you paid?
Your Excellency, for the providers of technology, SHA has only paid around 500 million. How does SHA calculate this, Your Excellency? It is in our regulation. We went to the Kenyan people, and the Kenyan people told us for the Social Health Authority, within their 5%, they only pay 25 shillings for every active member of the Social Health Authority. So anytime the Social Health Authority has an active member, you pay 25 shillings, not per month, Your Excellency, but per year, Your Excellency. For the last 2 years, around 500 million, Your Excellency.
So 500 million paid for this technology that we were told that we were going to pay 100 billion.
Correct, Your Excellency.
Okay, so the writers of the headlines have answers. Let me also ask you, maybe Mercy this time round. So, because of the efficiency we are building, first, how many gadgets have we supplied, and how much did the hospitals pay?
Your Excellency, as of today, we have supplied 42,327 gadgets. If you walk to any of your dispensary today, in the lowest village you can be, you will find a gadget there, Your Excellency. The hospital has not paid for a cent.
They have not paid for it. We have provided those facilities.
Yes, Your Excellency.
And it is part of the digital health system.
Yes, Your Excellency.
Mercy, you inherited an organization called NHIF.
Yes, Your Excellency.
With 1,000, how many workers, and how many workers do you have today?
Your Excellency, we inherited an organization that had close to 1,737 workers. Today, our establishment has 815 health workers who work at SHA. And Your Excellency, just because of that technology, we've been able to halve our workforce, but also additionally, Your Excellency, increase our claims processing. I think it is important for Kenyans to understand in any one single day, 24 hours, SHA receives about 26,000 claims. These are 26,000 Kenyans who've walked in and walked out of a health facility and a claim has been lodged at SHA. And because of the system and the digital components that have just been described, the SHA Claims Management Office that has 35 people. 35 people. They're able to go through 26,000 claims in a day and close to 1 million claims in a month. That's the efficiency we've gained.
We inherited an organization of 1,700 plus. We have taken close to 1,000 Kenyans back to public service to go and do something else. We have remained with 800 in SHA. So we have reduced by half the staff because of technology. And we are processing more claims than were being processed by 1,800 staff. That is how efficiency looks like. And that is how transformation is framed. And that is what we have achieved. I don't know whether, Mercy, I have answered your question.
Almost slightly. The one that is still top of my head is the reforms that we are talking about were passed through Parliament. And I'll narrow down to SHA. One of the headlines is the members of Parliament saying that SHA is not working, but they passed this law. I don't know, I cannot reconcile those two things because our laws pass through these members of Parliament. It may not be your question, but the buck stops with you.
Okay, Mercy. You know, there are many facets of this. Maybe I remember that at some point, you know, because of the challenges that were there in SHA, some people were almost giving up. Because what we have done in transforming SHA or NHIF to SHA is something phenomenal. You know, we replaced one piece of legislation with 5 pieces of legislation. We transformed a whole ecosystem. You have heard what Antonia said. We had all manner of, you know, challenges from that fellow called Mugo, who was not a doctor of any shade, but he was busy treating people in some clinic. Because of technology today, Mr. Mugo has no job. He cannot fake anything. From that all the way to the hospital we had in Kino that was doing surgeries, more surgeries than Kenyatta Hospital. Today, the gentleman in Kino has no business because the fake things he used to do is not possible anymore. Same thing to the fake claims we used to have. I said earlier, we used to have claims of people, somebody who has been amputated 7 times. And then you ask yourself, how many legs did this person have? That is no longer possible today. And we had some hospitals that had more accountants than health workers. You ask yourselves, what are accountants doing, more accountants doing in a hospital? Because it was a fraudulent claim making enterprise more than they were hospitals. We've stopped all that. And that is the reason why this exercise has been a big battle. Those people who lost their schemes and enterprises, sponsored headlines, sponsored cases, because we were interfering with their business. But I can proudly stand here today and say the people of Kenya finally have a system that they can audit, that they can see, and that is functional. And today there are witnesses across the nation. Go to any village, go to any part of Kenya. Even when you go to a fundraising event, and let us call a spade a spade. The WhatsApp groups that we all used to have in our phones have gone down. True or not true? Yes, the WhatsApp groups have stopped. Even when you go to a fundraising today, they will tell you, SHA has paid 300,000, we are looking for 100 or 200,000. It used never to happen before. So, statistics, numbers, have a way of saying things better than any statement. So, Mercy, we have members of this parliament here. I don't know whether we have a member of parliament there. Do we have any other member of parliament? Please, who want to, it is said that you as members of parliament said SHA does not work. Mutueleze, come up from your point of view.
Your Excellency, my name is Senator Jackson Mandago. I'm the chair of the Senate Health Committee, and I want to stand here to confirm, Your Excellency, that SHA is working. The period members, a few members of parliament were saying it was not working, was actually during the first phase of implementation. With DHA, Your Excellency, when they supplied the gadgets to all health facilities, all Kenyans were now able to access SHA. In fact, I've just received a message from one of the members of County Assembly who said he was admitted in June 14. He's a former nominated MCA, Duncan, and SHA paid all his bills. SHA is working, and there is evidence that it is working.
Esther, do you want to contradict what Mandago said, or yeah?
No, Your Excellency. SHA is working, but I think the biggest failure that we're having, that the Ministry of Health has to undertake, which we try to do as in terms of civic, is to educate the people on how to onboard, how to review their funding model if they're having a problem with the premium that they've been given. Because every single day, and then to have an effective customer service line, an effective one where any citizen can call English, Swahili, and get information. Because yesterday I got a phone call from a lady who was admitted in Nazarene. Immediately I called somebody and I said, this is the SHA number, this is the ID number. They are being detained because what happened is, and this is something we need to educate Kenyans, as soon as she was admitted, she signed up. But she had already been in hospital like for a week. So the bill came to about 100,000. Now, such cases, I think the hospitals need to be educated. When you're admitting somebody, you need to make sure that they are registered. And then also the effective advertising. Social media is so cheap. Ministry of Health has to continuously educate Kenyans on how to onboard, how to have your premium reviewed if it's too high. How, before we used to say there's a waiting period of 3 months. Now we don't have a waiting period. But this lady in Nazarene Hospital is being detained because of 100,000, and the reason is because she joined 1 or 2 weeks after admission. So that waiting period, how do we deal with it? So I think it's important that the Ministry of Health really does a lot. They're letting you down.
Is there anything members of parliament can do?
I mean, we do civic.
Apart from asking the ministry, which you are right?
Yeah, we do civic. Every time we have an event, like if I have an event from GAF, I will call SHA to come in and talk and educate to on board. But now, because of the biometrics, it normally has to be done in the hospitals. But I've seen that they come in as well and they're doing it in most of my events, but it's not enough. We're not netting everyone. I mean, Nairobi has about 5-6 million people.
So information?
Information, online, information, with the CHPs.
Do you have a working line, Mercy? And she said you need a working line, helpline.
Yes, Your Excellency, and we do take the comment seriously. We are doing more to talk to Kenyans. We have the line 147, and it's accessible 24 hours, but we also have a county infrastructure. Each of the 47 counties has a SHA office, and additionally, we have SHA officers too per Huduma Center across the country. But that being said, Your Excellency, we do take...
what did you say the number was again?
147. 147.
So a citizen can dial
147.
147.
And it goes to our call center that has callers waiting there to attend to the citizen.
Do we have people who speak Swahili there?
Ndio, tukana Wakenya ambao wanaongea Kiswahili hapo.
That is what Esther was asking.
Kuna Wakenya ambao wanaongea Kiswahili kwa call center.
Kwa hiyo call center.
Ndio.
So to everybody listening to us in every part of Kenya, it is good for you to get information. And the information you can get, if you don't get from your CHP, if you cannot get from anybody, dial 147 and you can ask any question and your questions will be answered. And for people like what Esther has said, that there is a citizen who was admitted without registering for SHA, and then she registered halfway through her treatment or his treatment, that needs to be looked into. How do we manage that? Do you want to say something, Mercy?
Thank you. Thank you for that observation, Mheshimiwa. One, Your Excellency, we must remember and remind Kenyans that for them to be able to access the SHIF benefits, they must register and they must contribute before they go to hospital. When you go to hospital for a week or even 5 days, 3 days, SHA needs that visit to be notified in the system. So it means for those 3 days, 7 days, there's been no notification at SHA. It means SHA cannot verify that that is an actual visit. It means any pre-authorization was not done, and SHA basically is blind that you're in the hospital. So Kenyans need to be reminded that if you need to be able to be admitted and you need the SHIF benefit, Register, pay for it before you go to hospital. Once you're in hospital, the hospital should provide us a notification of your visit, and we start tracking your care and treatment. So it is important in controlling fraud and ensuring that we're able to actually be accountable for that money that we shall pay the provider.
For example, I think I talked about Lydia. I don't know whether Lydia is in the audience. Do we have Lydia in the audience? I talked about Lydia. Is she there? Ako hapa Lydia huyo? She's not here?
She's right
Ako wapi?
at the top there.
Lydia traveled from Matu today, Your Excellency. So she's right here with her mother. Yes.
With the mother?
Yes.
Mama ako hapa?
Yes. Guardian ako hapo.
Wapi mam? Oh, yuko pale. So, like the case of Lydia here, who developed a complication. Her mother had paid 7,000 shillings as her contribution to social health insurance fund. Mama, hebu tueleze, mama yuko pale. Mama, habari? Habari yako mam?
Salama.
Very good. Unaitwa nani?
Mimi naitwa Naomi Mutendwa.
Naomi, wewe ndio mama wa Lydia? Very good. So, uliregister kwa SHA? Ukalipa pesa ngapi?
10,200.
10,200. Alafu mtoto ulimpeleka hospitali?
Nilimpeleka hospitali.
Akatibiwa?
Hapa Kenyatta akatibiwa, lakini nilipeleka Garissa nikaambiwa nimlete Kenyatta na akatibiwa na katoka vizuri.
Okay. Bili ya hospitali ilikuja pesa ngapi?
Ilitoka na 1,168.
1,168. Ulilipa shilingi ngapi kwa hiyo 1,168?
Hakuna kitu nililipa.
Huyo msichana wako akatoka hospitali akajiendea nyumbani. Na nimeambiwa ya kwamba anafanya form 4.
Anafanya form 4 sasa
mwaka huu. Lydia, my very best wishes on your exams. Ukienda. Na asante sana mama kwa kuja. Kwa sababu niliongea mambo yako, nilielezwa na watu wa SHA mapema leo. Asante sana kwa kuja. Now, unaweza keti mama. One of my staff, Dr. Mwai, who worked with me on this program, and I remember sitting down with Dr. Mwai in 2021. 2021. I don't know whether Dr. Mwai is in the audience. Okay. You know, Dr. Mwai was telling me about an experience he had, I think in the last 2 weeks, about somebody who called him and asked him, why are you people asking me to pay 8,000 shillings? Can you tell me? I remember you mentioned to me, Daktari.
Yes, thank you very much, Your Excellency. The issue was when you are dealing with the issue of are we charging people more? So the first thing that people have argued is that we should have introduced waiting time. I hear a lot of that. But you said that when somebody is in problems, you don't tell them to first wait. So when they come in, they pay, and then you cover them. So a friend of mine who I consider reasonably learned, in my own opinion, called me and asked me that they are trying to revise their premium because their premium is around 8,000. And I asked her, you want to revise the premium? Why? You have a patient? Is it a new person? Are you preparing for any eventuality you get sick? So he told me that the patient is actually receiving dialysis or want to start the dialysis. So I asked, the dialysis, SHA is paying 10,650 per session. Majority of them take 2 sessions. So laugh rate 21,300 there. All right. Now, they pay that for 52 weeks in a year, which is 1.1 million plus. Now, I asked my friend, where were you come to a little bit to me, Somakido? SHA is, you are saying your patient is in hospital, you want to pay 8,000, you get 1.1 million. Now, you're my subus in rice. What is a no-brainer? You are complaining, yet you can already see the benefit SHA is giving you far outweighs the cost, actually, what you are doing. Akanyamaza na akalipa. So why I'm saying this is because there is also a move for people to not want to understand the money we are paying with, where is it coming from? It's coming from each and every person, contributions based on ability to pay. And that is what you correct, so that somebody who paid 8,000 receives a benefit of a dialysis at 1.1 million. Thank you, Excellency.
The point I'm trying to make here is we have said the following. We have said for outpatient, every citizen of Kenya, so long as you are registered in SHA, you will walk into any facility, public, private, faith-based facility, anywhere in Kenya. So long as you're registered in SHA, you will walk in and walk out without paying a single cent for outpatient facility. If you have to be admitted for surgery or for other facilities, that is when you have to make a contribution. Or the government of Kenya, if you are not able, the government of Kenya will pay for you. But you will be assessed, and everybody will be assessed for what they can pay. For the case of Mama Lydia, she was assessed for her and her family. She was assessed for 10,200, as she said, for a whole year, for herself and her family. Lydia alone, SHA has paid 168,000. If her next child became sick, they will be paid for. If she became sick, she will be paid for the next 1 year, for paying 10,200. Right? Simple mathematics. That is what that gentleman in the clip was saying. It must be contributory on ability. That's the point I'm trying to make. So we must all understand that for this to work, we have first removed. In NHIF, you paid and waited for 3 months for the cover to be active. In fact, many people are pushing me to say, why don't you go back to that? No. You cannot tell a sick person, pay, wait for 3 months so that you can come for treatment. What about if they die? Or if something happens to them? So the moment they come to hospital, if they are not registered, we register them, they pay immediately, and they access service at that point in time. That is how we have changed the metrics. And that is how we are going to do it going into the future. I remember saying also earlier about cancer. You know, we had a big problem with cancer, as we all know, and treatment. We have again upped resources for cancer from 500,000 to now 800,000 cover for all citizens registered under SHA. So that is the trajectory. I don't know, Mercy, whether, again, I have answered your question.
Yes, Mr. President, but I don't want to be accused of inviting you to a town hall of this magnitude and asking all the questions. I think we should let the Kenyans here also ask some questions, and I'll hold mine for later so that we can field questions from the room, if you allow that. So, You can pick.
So I'm the one to pick I thought you were going to do
Yes.
that for me. Okay, I see some beautiful lady there. Madam, you have the floor.
So, good evening, Mr. President. My name is Lois. I'm a person with albinism, and I stand here to speak for persons with albinism and persons with vitiligo. For us, sunscreen lotion is an essential. It's not for cosmetic purposes, and mostly it's not covered using the social insurance cover. So, whom do we go to, or what approach do we take for us to make sure that we have it, since most of the times the government provides it, but it is not enough, and at times it's not there at the hospitals. So how do we go to, where do we go to, or how can we go about it?
Very good, thank you very much. Did you say, what's your name?
My name is Lois.
Lois.
Yes.
Lois needs an answer. Yeah? Lois needs an answer.
Thank you, Lois, for that question. Your Excellency, vitiligo, I'm not a dermatologist, but I'm a doctor. And vitiligo is a condition where the cells that are called melanocytes in your body are not able to produce the needed melanin. Now, the problem with patients who suffer from vitiligo is that they're exposed to the sun, and because of that exposure to the sun, they're at risk of getting cancer. And so actually we need to protect patients who have vitiligo by ensuring that they have sunscreen, they have the necessary steroids, and they also have UV light therapies. The madam is correct. In terms of our current benefit package, what we have in offer as government is that KEMSA, and I hope Dr. Wako is in the room, do procure sunscreen at subsidized rates to be able to ensure that those who have vitiligo can access that sunscreen. However, at SHA, we have not yet started reimbursing for sunscreen, so you won't be able to get it from SHA reimbursements. Your Excellency, the case of vitiligo accompanies many other cases when it comes to healthcare. And what is important for our country is to start on a journey of progression. As we start here today, we are covering a large burden of disease, the things that cause the most harm. We are by no means saying we cover everything, but there is a scientific process of being able to determine how we add more benefits into our package to be able to cover everyone. And that's the journey of UHC that all countries must go through. So the short answer right now, Your Excellency, is that when Madam needs care, she'll be able to go to a PHC center. But unfortunately, what she needs in terms of sunscreen and some antisteroids are not yet available in the package, but will be available as we continue mobilizing more resources.
So what do we tell Lois? Do we tell Lois
Coming soon?
How much time do we need? And Lois, I agree with you. We have a huge benefit package. And I remember I sat down with my team and we said, we need to look at a benefit package that we can afford. Let me tell you, Lois, today we are paying 2.75% of our income. We should know that countries that provide universal health coverage pay up to 15%. Go to any country. It is not 2.75%. It is 15% for them to provide the full package. We have started with a package that we have. But I think, to be fair to people living with disability and others who have conditions like the one Lois has said, including vitiligo and all the others, I think it is time that we come back to Lois and tell her at what point will we include the sunscreen she is looking for. And I want to tell you this, Lois. It is homework you have given to me. let me take it home.
And Your Excellency,
I will have an answer for you and for all the others who are like yourself.
And Your Excellency, just to add, you've actually commissioned the Ministry of Health to review the benefit package, and you've given us a deadline of ending October. So all Kenyans are invited. We'll be having public participation on the new benefit package for SHA, and we'll be looking for Lois and all other members who want more benefits to be included. And we'll give the reports on the new benefit package at the end of October.
Thank you very much. In our midst, I want to listen to a manager of a facility. I have said here that facilities, I want somebody who runs a health center or a dispensary.
Mr. President, we have one on standby at Riruta. If we have that link ready, yeah, we have Alice Ndwiga at Riruta Health Center. But as we get her ready, maybe we can pick one from the room.
Do we have a manager?
Here she goes. This is Alice Ndwiga.
Okay.
County.
Alice Sabari.
Good evening.
Good evening, Alice. How are you?
I'm very well.
Habari ya Riruta?
Riruta iko baridi mingi, but tuko salama.
Very good. Tell me, Alice.
Yes, please.
Before UHC, is there a difference between are you a manager of that facility? Or
Yes, I am. Maybe I can introduce myself, His Excellency. My name is Alice Ndwiga, Facility Manager at Riruta Hospital, Level 4.
Yes.
We are here at Dagoretti Sub-County.
Okay.
The North.
Okay.
Kangwari Ward.
Let me ask you, Alice. What is your experience as a manager? The journey over the last 3 years. What is your experience? How has your facility improved? What difference has universal health care SHA made in your facility?
Okay. Thank you, His Excellency. So to just begin, here at Riruta Hospital, we do have a good expansion of services, and that's all in contributions that we've had from the SHA reimbursement and also the expansions on the PHC services that we have. In addition to that, we started with 200,000 that we were getting in a year with the NHIF, but now with SHA, we have between 5.5 to about 6 million that we've been able to have an increase when it comes to SHA. In addition to that, we've been able to do a lot of expansion of services, like I'd mentioned. We'll be able to have the services where we were able to have before the TB on the outpatient and also the NCDs as well. So in addition to that, we were able to have addition on the theaters that we also have, the NBU that we're also able to manage to have our bed capacity that is about 10, and the most importantly is our workload that we're able to have our increase of our patients from 200 to now 400 patients per day.
So you're telling me that you used to get reimbursements of around 200,000. Is that correct?
Yes, His Excellency.
Per month?
Yes, His Excellency.
What is your reimbursement now from SHA every month, on average?
From SHA, we about between 5.5 to 6 million a month.
So it's gone up.
It's gone quadruple up.
How are you deploying that money that you get in your facility? For what are you using that money?
Okay, so for one, we have been able to expand our services. That means from our end, we were able to have our lab machines that we were able to buy too for the full hemogram and also the biochemistry machine as well, and that has expanded our services when it comes to Riruta service. Then number two, we've been able to do the theater. We've been able to expand our services on our end, and also the NBU. that we're able to expand to 10-bed capacity. So for Ruruta Hospital, the reimbursement that we've been able to get for SHA, it has been able to expand our services and also be able to have our areas where, when it comes to not only equipments that we're able to get from the SHA reimbursement, we are also able to get the gaps that we're able to have into the service delivery here in Ruruta Hospital.
So, Ruruta is it a dispensary or a health center?
It's a health center.
So when I made a commitment,
but with the addition of...
Yes, sorry, please continue.
Sorry, with the addition of the services that we'll be able to have, the hospital will be able to move from the health center level 3 that is in now to a level 4 that is going to be comprehensive of all the services.
So my question to you, Alice, is that...
Yes, His Excellency.
I did make a commitment to you and to facilities like yourself that we are going to have a system that will improve service at that level, at level 2 and level 3. Can you confirm that that has actually happened?
Yes, I can definitely confirm. So, for example, right now the theater machines that we're getting installed here for the theater and also for the NBO, they're actually coming from the NESP. That's the National Equipment Service Program that we are very glad, His Excellency, to be able to support the facilities when it comes to equipping the hospitals. And also with the contribution from the FIF that we're also getting in the hospitals, we're able to also expand the services and the equipments that are needed. And also to get the medication, Your Excellency, I can be very proud and actually say with a lot of confidence that I don't miss drugs here in Ruruta. I don't miss that's non-pharmaceuticals and lab reagents. So those are the 3 areas that I make sure that when we are doing our reimbursement that is coming from SHA, our FIF that we get from the hospital, we make sure that it's getting back to the patients and also the community at large. Then to also mention, we do make very good food, His Excellency, for our patients.
Thank you very much, Alice.
Our maternity.
I want, thank you very much, Alice, and my very best wishes as you provide service to Kenyans there, and good luck with what you're doing, and congratulations. Thank you very much. We're really proud of what you're doing
Thank you.
in
Thank you for this.
In Ruruta. I want somebody live here who is a manager of a facility to be able to tell us here, you know, do we have a manager of a facility? Yes. Are you a manager of a facility?
I'm the County Director of Medical Services. And
Proceed.
Yes, my name is Dr. Eliza Ikiara. I wanted to highlight some of our facilities, how they're doing before SHA. For example, Ugweri Dispensary, one of our, we're in Embu County. Ugweri Dispensary, which is a level 2. With NHIF, they never used to get anything, 0. But with SHA, with the PHC, they are getting around 6.4 million in a year. And also we have Gategi, that's a health center, Gategi in Mwea sub-county, which gets around 9.6 million now in a year. And the other one that we have is Kianjokoma, which is a health center in Runyenje sub-county, which has around now 10 million. And with that, they are able to procure medication, lab commodities, and non-pharmaceuticals for themselves, and don't have stockouts anymore that we used to experience before. And also, they are able to also, for example, Gweri was able to install CCTV cameras in the dispensary.
What do you have to tell to the people who say SHA is not working?
And for me, I would say for us in Embu County, we have seen the difference. We are getting, our revenue has increased exponentially. We are not running out of drugs. We have refill rates of 80% and above. And even Embu County scored highly in our pharmaceutical dispensing rate that was done by, we had 72%, meaning 72% of the clients get the whole prescription filled at the facility.
Do we have, thank you very much, Daktari. Do we have a facility manager? I want somebody who runs, do we have somebody here? I really want somebody who runs, do you run a health center? Yes, please, give her the mic. Tell us your experience.
Thank you, Your Excellency.
Your name first.
My name is Gladys Chebet. I'm the facility in charge, Ngaira, which is just across here.
In Nairobi?
Yes.
Okay.
Just here at Technical University.
Okay.
Yes.
Proceed. What is your experience of the difference? Has SHA made any difference in your facility?
Yes, yes. Before SHA, we actually used to get some funds from Danida, which was around 270 to 50,000, which actually never used to cover everything. But right now, I've been able to claim over 7 million. And we've been able to procure a full hemogram machine. Our laboratory is working optimally, yeah. And our pharmacy is full. In Gaira, we are running a NCD clinic, which has around 1,600 clients. And they are all going home with very good drugs. And SHA in our work, yes.
In short, SHA in our work?
Yes.
Okay.
And sorry, we have been able to improve our infrastructure. Yes. It used to be a very old facility, but right now, it's good.
Very good. Thank you very much. Do we have another person who runs a health facility? Do we have a person who runs a health facility? No. Okay. Let me go to the second item. You know, KEMSA, I have said here that KEMSA has increased the refill rate. I made a statement earlier. And Wako, the CEO of KEMSA, is here. We have taken refill rate for requests from hospitals from 40%, meaning that if a facility requested for 10 drugs, we could only provide 4. We've moved that to 91%. And among the best performing counties, and we must give credit where it's due, is Kilifi County. The governor of Kilifi is here, Governor Gideon Mungaro. Mr. Mungaro, Governor, can you tell us ama utueleze kwa lugha ya Kiswahili mambo vile yalivyo?
Thank you, Excellency. When I took over in 2022, August, the first few orders, first we had a very big bill of 429 million inherited. We negotiated with KEMSA, but for the first 1 year and a half year, we were getting between 38 to 40 of our orders. But I remember after our last summit when you promised, because as a country we have really tried to buy from KEMSA, because we have two advantages, Your Excellency. Apart from when we started, we had only 38 to 40%, but one thing you can be sure, the drugs you buy from outside KEMSA, 10 million you buy from KEMSA, you spend maybe 30, 40 from other entities. So since 2025 coming 2024, towards the end of 2024, it started going up. The last two orders we did to KEMSA, we got 183%, and the last one we did a few months ago, we got 70%. Probably we tell Wako where he needs to improve is on surgical gloves, which we always have a challenge sometimes, and the other gloves, I don't know if the doctors call them what? Sterilite. Because sometimes you go, they are there, but you get number 7, and some doctors are very big hands, you need number 8. So maybe that's where we need some improvement. But I must say, since I came to office, Your Excellency, I bought drugs 1.6. I bought from outside before when we got only 38 to 40. But I have bought from KEMSA, and the worker will testify that I bought as a county drugs worth 1.6 billion and 80 from KEMSA.
Thank you very much.
Thank you.
Gideon Mungaro and I are not doctors, so forgive us if we don't know some of the names of the gloves and all that. My CC, Your Excellency, can talk something. I know you wanted only
facility managers.
Yes.
But my facility manager will return from the gate because they said they know him.
Okay.
But he can tell you something about KICC Hospital.
Okay.
Because it is completely a change when we started doing SHA.
Yes, Your Excellency, I can confirm here that there's been quite a transformation since we started receiving the SHA reimbursement. We have been able to expand our hospitals with equipment from 2 theaters. Now our referral hospital, we are operating 5 theaters, which means patients don't have to wait for a very long time. Another hospital, we started with 1 theater, now we have 2 theaters. And in the 3rd hospital, we now have 4 theaters. And all this equipment we're buying based on the reimbursement we're getting from SHA. So there's a lot of transformation. And as far as the procurement of drugs is concerned, through KEMSA, Your Excellency, we've seen tremendous improvement. From the 40% which we started with to now we're getting 83% of our orders, and even with that 83%, we still get back orders to fill the difference, which we still distribute to our health facilities. And for the SHA reimbursement at our primary care facilities, that has really improved our drug availability because they are able to spend at source to procure the higher support staff with the money. And therefore, we've really improved services using SHA. Thank you.
Let me ask you, are you a doctor?
I'm not a doctor.
You are a manager?
Manager, yes.
Let me ask you, before we did not have the law on Facility Improvement Financing Act. What difference has it made? Because under NHIF, money was being sent to the county. Then it was up to the county to decide which facility to go improve, which facility not to go improve, which facility to buy medicine for, and which facility not to buy. Today, every facility is reimbursed their money. Is that the case?
Your Excellency.
And how has that helped in making sure that there is delivery of service?
Your Excellency, the implementation of the FIF Act has tremendously improved. First of all, the fact that the facilities themselves are able to spend the money at source is an incentive for them to make sure that they generate more. Therefore, they contribute to recruitment of members to SHA so that they can be able to have more resources to spend. But more importantly is the fact that they are able to make the decisions based on the priority of the hospital at that moment. They don't have to consult elsewhere or wait for resources from the county treasury to make funds available at the facility. They're able to prioritize and act on the spot as they receive the reimbursement from SHA. Thank you.
Very good. I want to ask one more question to either a CZ of health
Your Excellency, I wanted to add from where the CC, he didn't elaborate something. The KICC Referral Hospital, we used to collect about 1.7 million a month, and now we are 30 million. Malindi used to collect 1 million, now we are 16.5 a month. So that is the change I thought the CC will explain.
And that is the money, Gideon, you are using to improve the facility.
Yes, we pay even locum nurses from that money.
Yes, you pay some of your staff.
Yeah, and all the casuals who work in the hospital or contractual workers.
And also to improve the theaters and all the other facilities.
Like the 5 theaters he was talking about, we just did them. They are 3 weeks old.
Using money reimbursement from SHA.
Generally, when we took over the county, the hospitals, the level 4 hospitals and the KICC referral were collecting in total 176 million in 2022 to 2023 June. Now we have collected before we have collected 900 this year, 900 million from 176.
Okay. Let me ask one more, CEC, because, you know, it's good for us to listen from practitioners on the ground, not people who are talking from political podia. Do we have, I want to ask a question and I want a CEC to answer me.
We have one.
Is it correct for me to say, just as I committed to the people of Kenya, that today dispensaries, health centers are more empowered to make decisions on how to use that money, which drugs to pay for, which theater to improve, what facility to improve in every facility? Is that the case, or they have to wait for a county to decide or for somebody else to decide? Are you a facility manager? You're a CC. Please tell us your name and please help this audience and others listening to understand.
Yes, my name is Dr. Gregory Ganda. I'm the CECM in Kisumu for medical services. It is true that with the FIF Act, now facilities can make their own decisions. But it is even better because the facility board is made up of members from the same community. So they oversight these funds. So whatever the facility decides, the technical people make decisions, and then they get the oversight of the community. So the decisions about that funding and how that funding is spent is both technical, but also involves the community. So I can confirm that, yes, this is true.
So, and I remember giving an analogy that the same way you have a school management board helping us to manage our schools, to build classrooms, and to make sure that the facilities are there. Today, our boards, which are members of the community, they are the ones who oversee the money we reimburse these facilities. They are the ones to decide that we want to make sure that there are enough health commodities. That is medicines and all the other things. We need to repair, we need to buy this equipment. We need to buy the other equipment. That is the case, Daktari, is it?
Yes, that is the case. We allow them to make decisions, but of course we oversight them sometimes. Like for most facilities right now, in most counties have given a minimum, because sometimes they might decide, you know, members of the community can say build the gate and build the wall and all that, and then you don't have enough medicine. So we are giving them a minimum percentage. Most of us are doing 40-50%. Half the money must buy medicine, because the biggest problem of Mwananchi is hakuna dawa. So we don't want anybody to come here and say hakuna dawa. Once that is sorted out, maybe you can pay it, you can do other things.
Very good.
Thank you.
I want to ask one more question. Just sit down, Daktari.
Thank you.
Because, you know, we need to answer to the things that Kenyans want to hear. Number one, we said we are going to empower every facility to make decisions. We send the money not anymore to the county, but we send reimbursement for every citizen a dispensary treats. For every citizen a health center treats. We send the reimbursement to that dispensary. If they treat 20 people, we send reimbursement for 20 people. If they treat 1,000 people, we send reimbursement for 1,000 people. But financing is not the only challenge. The other challenge is equipment. To be able to provide service, you need the theater, but you also need equipment. And this is what we did. And I want CECs who are here to confirm, and even our friends, the governors who are here to confirm. We did the following. We said that it is not possible for some of our facilities to buy an MRI machine, to buy a CT scan machine, theater machines, IC, whatever. Many of these facilities are expensive. They are in hundreds of millions, tens of millions, some of them in hundreds of millions. And so we agreed and we designed a program called National Equipment Service Program. Yeah? And how did we do it? We said, let us pool all our facilities and negotiate together with manufacturers. Because it is difficult for manufacturers to go and negotiate with a dispensary or a health center alone. But if we pool together through the economies of scale, we can be able to have the muscle to negotiate for better prices, better facilities, and also for the manufacturers, it is easier for the manufacturers to deal with us as one entity than to deal with us as individuals. They are assured of their money being paid, and they are assured that every facility is going to pay the rate. So, today we have equipment supplied by manufacturers, equipment that has not been paid by the facilities. In the past, under the MES program, Managed Equipment Service Program, we paid almost 63 billion for equipment, some of which did not work, some of which broke down and there was no service, some of which we did not even have the reagents and consumables, and it was very problematic. So we thought and said, let's do it differently. I want to know from either a manager of a facility or a CEC, what is their experience? How many equipments have they got? And what is their experience with the equipment that is being supplied under this framework? Do we have a manager of a facility or a CEC? I think I have some gentleman there. The gentleman in some brown, nice suit.
Asante Mheshimiwa Rais. Jina langu ni Daktari Martin Wafula, Mutuini Hospital. Kwa kweli ule mpango wa kuleta vyumba kazi kwenye facility zetu imetusaidia sana. Kwa sababu ya kwanza, hatujalipa hela yoyote ili tuletewe machine za upasuaji kwenye hospitali zetu. Kwa miaka ambayo nimekuwa hapa karibu nikifanya kwenye mahospitali kadha wa kadha, kutengeneza theater unahitaji pesa ya chini kabisa ni milioni 50 ili uweke theater ambayo ina vyumba kazi, ina mashine ya kutosha na pia ina instruments. Lakini kupitia huu mfumo wa NESP, facility zetu kwanza ya kwangu ambayo niko namalizia, nimepewa theater 3. Na hizi theater 3 zinakuja na mashine ya kupeana anesthesia. Pia inakuja na mashine ya upasuaji ya kitanda. Pia inakuja na mashine ya kupeana mionzi, radiotherapies na x-rays. Manake hivi vitu baadhi yetu, Mheshimiwa Rais, baadhi yetu na ndugu zetu ambao wamekuwa kwenye vyuo vikuu wakisomea taaluma ya udaktari hawakuwa wameviona, ndio mara ya kwanza wanaviona kwenye hospitali zetu. Jambo la tatu, kuna baadhi ya mashine, kwa mfano endoscopy. Mheshimiwa Rais, mpango wa endoscopy, wa colonoscopy, hizo surgeries ambazo haupasui mtu, unatoboa kashimo tu alafu unapasua mgonjwa, baada ya siku chache ameenda nyumbani. Hiyo ni heko na ni kitu ambacho lazima tujivunie. Jambo la 4 ambalo mkurugenzi wa DHA aliliongelea, Mheshimiwa Rais, kwa mara ya kwanza kwenye hii nchi ya Kenya tuna mfumo, na mwenye anataka kujua aje Mtuini kesho ama aende hapo sasa hivi, mgonjwa anaonekana akiwa wapi, nyumbani, na hili limefanya tukapunguza idadi ya kupoteza wamama. Kwa mwaka mmoja miezi mitatu, Mutuini hospitali haijapoteza mama hata mmoja. Kwa sababu gani? Tunatumia telemedicine platform. Aidha, Mheshimiwa Rais, haya magonjwa endelevu, non-communicable diseases, haya magonjwa yamekuwa tondazugu zaidi, na jambo ambalo linatuzuia, tunao madaktari bingwa wachache. Kwa mfano, unaweza kuwa tuna daktari bingwa wa upasuaji wa ubongo mmoja ama wawili, lakini kutumia mfumo wa telemedicine ambao DHA imetupa, tunaweza ona mgonjwa mahali popote pale na ule daktari apeane mwongozo. La mwisho kwenye teknolojia ambao pia imekuja na SHA. Mheshimiwa Rais, tulikuwa na kitu inaitwa rejection rate ya claims, lakini kwa sasa tunaongea hivi, rejection rate yetu sasa hivi is less than 1%.
Pale Mutuini.
Pale Mutuini na pia kwenye mahospitali mengine ambayo ndugu zangu wako hapa, ukienda Mama Lucy, ukienda Mbagathi, ukienda Pumwani, hivyo ndivyo hali ilivyo.
Thank you very much. Nimesikia kwa mara ya kwanza daktari bingwa. Utanieleza hapo nyuma ya ndio ni kusema aje. Sawa sawa, daktari bingwa. Let me ask, can I get let me ask one of the manufacturers, supplier. Can we have a supplier of theater equipment, because that is what my brother there. Do we have a supplier here in this?
I can see a hand up there.
Do you have a supplier? One of the suppliers?
A supplier?
Are you a supplier? No. Are you a supplier?
No.
If you are not a supplier, please, let's be tuwe na heshima. So let's pick what first, because we want to know from our suppliers. Was any supplier invited to this facility? No supplier was invited. Because I wanted to know the numbers. Do you have the numbers of how many theaters, how many have been supplied in the country?
Yes,
how many,
yes,
the number of equipment, the number of
Yes, Your Excellency. Under the National Equipment Service Program, we have supplied 52 digital X-rays. Your Excellency, we have installed 72 ultrasounds. We have installed 6 mammograms. We have installed 39 CT scans. Your Excellency, we have renovated and equipped 67 theaters. Your Excellency, we have established 157 laboratories. That alone, Your Excellency, worth more than 2.3 billion. Your Excellency, as the CEO of Mutuini was speaking, he mentioned specialized surgery. So specialized urology, as we know, prostate cancer is one of the big 5 cancers. We have installed 4 specialized urology theaters. There's something that they call a urology tower. Your Excellency, we have also been able to install 4 specialized ENT theaters. We've installed 4 specialized maxillofacial. We have also installed specialized cardiothoracic and vascular centers, 4 of them. Your Excellency, we have able to install specialized plastic centers, 4. We have also been able to replace the LINAC machine at Kenyatta National Hospital that used to break down often, Your Excellency. Kenyans know this story. Your Excellency, we have also been able to do 2 MRIs, and 2 MRIs are on the way by the end of this month. Your Excellency, in total, we've been able to install machines worth 9.8 billion shillings without the national government paying for it and without the county government paying for it. And Your Excellency, as you had mentioned, the game changer here is in the technology, the latest technology. And Your Excellency, one of the biggest challenges that we also have with equipment management is that the technology changes quite quickly. And most of our public hospitals are not able to employ what we call biomedical engineers to keep up with the latest technology. And so the game changer here is to keep equipment at 98% uptime without having to call manufacturers to come in and out to repair. Often, Your Excellency, the CT scans that were installed long time ago, 2 years down the line, they get broken down. You need another 16 million to repair them. You have to fly in an engineer from Japan or from Europe, and Your Excellency, you've been able to completely resolve that problem.
So, at the moment, under this program, we agreed that the equipment is placed by the manufacturer.
Yes, Your Excellency.
It is maintained and repaired by the manufacturer.
Yes, Your Excellency.
Consumables are provided for by the manufacturer.
Yes, Your Excellency.
All we pay for is for a service.
And when the service is offered?
When the service is offered.
And it is paid for by SHA?
If the service is not offered, we don't pay.
Yes, Your Excellency.
And it is paid for by SHA?
Yes, Your Excellency.
I don't know whether the CEO of Kenyatta is here.
He's in.
Yes. Kenyatta is possibly the largest public health facility we have in Kenya. Dr. Lesiambe, can you give us your experience as a manager of one of the largest facilities? How has your theater improved? How has service improved or not in Kenyatta? And then I want the CEO of Tenwek Hospital, one of the largest private health facilities in Kenya, to speak and tell us their experience. This is the largest public facility. We will also listen from the largest private facility. Yes, Richard.
Thank you very much, Your Excellency. Let me start by saying that Kenyatta National Hospital is the second largest hospital in Africa. I apologize by, correcting you, Your Excellency, because it is the second largest hospital in Africa. In terms of bed capacity, we are second to Chris Hani Hospital in South Africa. Now, Your Excellency, when it comes to management of health services in Kenyatta National Hospital and providing quality health care, we have to have equipment. And at Kenyatta National Hospital, as we speak today, we have 32 fully equipped theaters from 12 equipped theaters in the last 4 years. And Your Excellency, I've had the opportunity to be in Kenyatta National Hospital for the second time. I was in Kenyatta National Hospital as a CEO in 2012 and 2013. Today, I've come back less than 1 year. I want to confirm to you, Your Excellency, that it's not only the issue of having the 32 theaters, but what it means is that we are reducing the waiting time for surgeries, for management of our patients. It used to take a long time, it used to take long periods, and sometimes it used to compromise the quality of healthcare for our patients. Today, we have 32 theaters fully equipped, and there is no patient who can wait for more than 2 weeks before they are actually taken to theater. And on emergencies, it is done within 24 hours. Your Excellency, this has also assisted us when it comes to imaging. We used to have only one CT scan. Today, we have 2 CT scan machines, the most modern, in terms of healthcare management. And therefore, we don't have any patients waiting for CT scans to be done, images to be done, for us to have diagnosis, and for doctors and consultants, to make decisions on how they can manage them. We have gone further on a very, very sensitive issue, which has been causing havoc, and I think a lot of concerns among Kenyans when it comes to cancer management. Kenyatta National Hospital in 2012 up to 2016 has only had one LINAC, or LINAC accelerator machine for management of or treatment of cancer. Until 2 months ago, now we have a second LINAC machine managing 150 to 200 cancer patients on a daily basis. Your Excellency, we expect also in the next 2 months, we are also going to get a third LINAC machine. Therefore, Kenyatta National Hospital, before September or October of this year, will have 3 LINAC machines. We will also get a PET scan before the end of this year, and we'll never talk about challenges of cancer management or cancer patients' problems at KNH for the next 7 years. So as I conclude,
just for context.
Yes, Your Excellency.
Just for context, Richard, the LINAC machines, the theater machines, did you have to pay for them, or they are supplied under our NEST program?
The 15 theaters machines that we received from the suppliers of NEST or National Equipment Service Program were brought in free. In fact, what happened is that they brought all the equipments, including the tables, they're also including the anesthesia machines, and all other equipments. What happens is that we have an arrangement where for each and every operation, they get a minimum of 15,000 or even sometimes a maximum of 15,000 shillings. If the operation is even going to cost about 300,000 or even 400,000, they only get 15,000. So the deal is actually too good for us. And that's why we decided to maximize getting all the 15 theaters. So we did not pay a penny for those theater equipments. We never paid a penny for the CT scans. We have never paid a penny for the LINAC machine. We have not paid a penny for the mammogram, which we have a modern advanced mammogram for breast cancers management diagnosis.
Let me, can you give us your experience on share reimbursements?
Thank you, Your Excellency. I want to go back to 2013 when I left Kenyatta National Hospital. We used to operate under NHIF. We have a bed capacity of we had a bed capacity of 1,800 beds. Today we have 2,200, almost 2,300 beds at Kenyatta National Hospital. NHIF patients were only 60% covered. We had only 60% patients on NHIF at KNH. Today, under SHA, we cover 90% of our patients, or 91 to 92% of our patients are under SHA. And we have managed to get, as I can confirm today, Your Excellency, we have received 4.2 billion shillings from SHA in the last 18 months. So, and I think as I've heard from one or two individuals from the county facilities, I want to confirm also that SHA works. And I can tell it to all Kenyans that we have had 1 million patients passing through Kenyatta National Hospital as outpatients. We have also had 900,000 patients passing through Kenyatta National Hospital in the last 1 year. All of them have been paid by SHA, including the emergency patients.
So, are you telling the Kenyan public that the 1 million people you treated in Kenyatta Hospital on outpatient came in, they were treated, given drugs, and they left without paying a penny, and SHA paid for them?
Yes, Your Excellency, I want to say this with no fear of contradiction. I've been there for the last, I think, 10 months, 11 months. That's what has happened. I can also confirm that 9 months ago, I was in Jaramogi Oginga Odinga Teaching and Referral Hospital. And I was there for 18 months. And Your Excellency, when I was there, we actually received, I was there when SHA started in 2024, and I left last year in June. We received 900 million Kenya shillings at Jaramogi Oginga Odinga Teaching and Referral Hospital in comparison to what they used to get under SHA, which was 266 million. Under NHIF, sorry, Your Excellency. So, and I'm also here with the acting CEO of Jaramogi Oginga Odinga Teaching and Referral Hospital, and he knows very well that we did that job together, and it happened. So I want to confirm